This is Infectious Disease for the Nurse Practitioner, Part 1. Just as a very brief review, just to remind you, you do have the responsibility to notify the state of any conditions which are concerning from the public health perspective. I've included the information on Maine. That will vary, of course, depending on what state you're in. In general, if you go to the website for whatever state you're practicing in, you can find a list of notifiable diseases. Usually those will be broken into two categories, one that you need to notify the state immediately, and the other in which it's reasonable to notify the state within 48 hours. The notifiable list for Maine is included here. It's easy to find this and print this out off the website. You can also report things on the website. Many of the things that you'll need to report are actually reported by the lab, so you are not actually required to report them, but if you have any doubt, you do definitely want to try to report them yourself. So what to report? All the things that you would expect. Of course, the process to report is going to be fairly easy too. There's a phone number, you can fax, or you can actually report them online, and the form can be printed out. So just to review the diseases that you need to be thinking about whether or not to immunize people for, and obviously this is focused on adults and with a special emphasis on the elderly. Influenza, yes, you do want to make sure to update people's influenza vaccine. The high-dose vaccine does not have any particularly evidence saying it's any better than the regular vaccine, but the standard seems to be to provide the high-dose vaccine to people over 65, the theory being that they cannot mount the same level of immunity and that they need that extra stimulation. Measles, mumps, and rubella are going to be pretty well restricted to anyone who is in healthcare who needs to prove that they are immune. Remembering that the lab test that you're going to do is a IgG for each specific test that you're doing, for each disease, I mean. So a lot of people will say, I did a titer. You can't actually order a titer per se at most labs. You have to order the IgG, which gives you a titer. Varicella also can be titered, so you have to order a varicella IgG. If one is worried about shingles, there is a vaccine available for shingles. The recommendations are somewhat varied. Right now, Medicare will not pay for the vaccine directly, although some Medicare D programs will. You also need to consider whether or not to give the vaccine at 50 or 60. There is some concern that if you give it too early, the effect may wear off. So most folks are waiting till age 60, but some patients will go to the pharmacy, hand the pharmacy their insurance card, and the pharmacy will go ahead and do it after age 50 if their insurance covers it. So it's a variable practice, but something that you're going to see, I think, increasing over the next several years. As far as pertussis vaccine, yes, elders should get a dose of Tdap if they have not previously had one. Note that that is the small p for Tdap, so it is a smaller dose of pertussis than one would give small children. It will boost their immunity. Most people have had their last dose of pertussis vaccine at age 4 for most of the folks that are elderly now, so they probably have had pertussis between that time and now and have some immunity from that, but it is probably limited. I did include a link for a CDC vaccine video that recommends what to do with adults. It's pretty basic and is probably better for patients than for professionals, but just to remind you that there are other things out there. Meningococcal vaccine is going to be pretty much restricted to anybody that has their spleen removed as far as adults. If there's an outbreak, it's possible that we will immunize adults, although adults in general do not have particularly much vulnerability to meningitis. There is a new vaccine out there, just so you know, the meningitis B vaccine. Meningitis B is a unusual strain of the meningitis bacteria, Neisseria meningitidis, which had an outbreak down at Princeton a few years ago, so the vaccine was imported from Europe, is now CDC approved. Some states are giving it regularly. Other states, it's very optional. Currently for Maine, it's actually very optional. A lot of the pharmacies, however, do stock it. I do make college-age students aware, just because many of them are going to live in dormitories, and so obviously being in a dormitory increases the risk of meningitis. Hepatitis A, I'm going to review the recommendations for the vaccine in a minute, but in general, unless someone is traveling or unless there's a specific reason, you're probably not going to give hepatitis A vaccine. Hepatitis B is recommended for healthcare workers as well as for diabetics. Again, the practices on that are pretty variable. Haemophilus influenza type B, I think, has been a major contributor to the decrease in ear infections and meningitis in children. It is not, however, a vaccine that we give adults unless, again, they've had their spleen removed. Pneumococcal vaccine we'll talk about in a minute. There's two different types, and you need to be aware of the differences between them. So specifically talking about the pneumonia vaccine, there's two pneumonia vaccines. The one you're probably most familiar with is the Pneumovax, which is what they call a polysaccharide vaccine. That's why it's PPSV23, because it has 23 strains. The polysaccharide vaccines are not considered to be quite as effective as the conjugate vaccines, but the Pneumovax has been around obviously a lot longer than the conjugate vaccine, which is the Prevnar. So as of right now, you give the pneumonia vaccine to folks that have had asthma, to smokers. You give it after age 65. As of right now, at 65, you're supposed to give the conjugate vaccine first, and then even though the recommendations are that you can give the vaccines 6 months apart, in fact, Medicare will not pay for it unless they're at least a year apart. So basically, you give the Pneumovax at age 65, and then the Prevnar at age 65, and then the Pneumovax at 66. If someone is younger and got their Pneumovax at 63, then you wait 5 years and give it at 68 as opposed to 65. But most people will have gotten their vaccine in their 50s, so once they turn 65, it will have been 5 years. So you give the Prevnar at 65 and then the Pneumovax at 66. Non-vaccine patients definitely provide a challenge to the clinician. Some practices choose not to take care of non-vaccine patients just because they are very difficult to take care of, as well as conceptually they feel very strongly that people should vaccinate. So for example, you have a 9-month-old baby, has an ear infection, had a high temp, now the neck seems a little stiff. Obviously, that child would not have had meningitis vaccine yet. On the other hand, they should have had several doses of the Hib vaccine, and Hib is a very common cause of meningitis. So unfortunately, in this child, you're going to be way more likely to have to send this child to the emergency room so that they can have a spinal tap to make sure that they're not developing meningitis. Obviously that'll be a clinical decision based on the amount of stiffness in the neck and your general impression of the child, but it does add a new element to the clinical decision making. 4-year-old boy with a red rash, he's not that sick, but his mom might be pregnant. So you need to go back, you need to make sure that mom's documented immune to rubella, and that there's no other risks. Another consideration, of course, would be fifth disease, but there's no vaccine for that. So, that would not have been able to be prevented by a vaccine. But him being immunized would have made the probability of rubella much, much lower, and therefore you would not have had to worry about his mom. 2-year-old girl with a cough that makes her vomit. Again, this would be the classic sign of pertussis, that post-tussive vomiting. The big concern, of course, is that she has a 6-month brother at home, and the hospitalization rate in children under 1 is at least 2 or 3%, and the mortality rate is substantially higher than it is with older children and adults. So again, it just adds the element of having to do additional testing. You definitely want to test this 2-year-old girl. You might, in fact, have to put the brother on Zithromax or some other prophylaxis as far as prevention, and the potential implications of children that have not been vaccinated require additional skills on the part of the clinician. Influenza, again, this is a vaccine that does seem to have substantial benefit as far as prevention of illness. We often will miss the exact strain, however. There's probably at least some benefit from being immunized at all, but if the exact strain has not been hit, they sometimes have to create another vaccine in a hurry. An example of this a few years ago was the H1N1. As far as testing for influenza, there's a couple of ways to do that. The rapid test is about 70% accurate, so that as far as trying to make some decisions, it can be useful. Many people, if you have a classic presentation, temp of 102, aching all over, known exposure, we'll go ahead and make the diagnosis on those bases without necessarily testing the person. Sometimes it is useful to test the person if they're a school teacher or someone else that you're really trying to figure out potential risks for other people. But as far as the actual person, it probably doesn't add much. There is a PCR which is more accurate than the rapid test. In patients that are hospitalized, then you really need to figure out exactly what's going on with them. This is a good test. For most office-based patients, this is not going to be necessary. And then there's actual cultures. So when you had people a few years ago who were getting very, very sick, were hospitalized, and you were really trying to figure out whether they had it, those people can have specific testing sent off to the state lab to figure out whether or not they actually have the virus. So there is a recommendation for early diagnosis and treatment. What treatment means, I think, varies a lot. The potential benefits of the medications are pretty limited, but there is definitely benefit of getting these folks isolated, giving them symptomatic treatment, and trying to get them better. Medications in influenza are very controversial. The benefit is relatively modest, depending on one's reading of the literature. You may not feel like they're useful at all. Other folks, because it is a potential treatment, feel like they just should provide this to the patient. The most common treatment is Tamiflu. Evidence seems to be that it might shorten the disease by a day. There might be a modest decrease in pneumonia, although the studies that have been done have been relatively small and have been done by the drug companies. The cost is not insubstantial. It's about $150. I think a lot of times we're feeling like, well, there's something we can do for people, we might as well do it. The problem with that is that the benefits are modest. there probably is at least some benefit in decreasing the infection potential of this person infecting other people. So that also should be taken into consideration. If I have someone that is around someone that's undergoing chemotherapy or otherwise immunosuppressed, I'm much more likely to go ahead and put them on the Tamiflu. If I have someone who's basically healthy and is around basically healthy people, then I discourage it. The benefit of shortening it by a day is really only an issue if you get it started within the first 48 hours anyways. Many people present after this time. There are a number of people who are on the verge of developing some kind of a pneumonia. There are people that will start those folks on antibiotic treatment to try to keep that pneumonia from turning into something bacterial. But again, that's always a judgment call in regards to the potential risks and benefits of antibiotics. Another medicine that you'll hear about is Relenza. Relenza is an inhaled medicine. A few years ago when we were having the H1N1, there were shortages of the Tamiflu, so we did actually use some of the Relenza. The other thing about the Relenza is that there is no known resistance to the Relenza, and there are some folks that might in fact have developed a resistance to the Tamiflu. The Relenza is a lot more difficult to dose. It's inhaled, and it's about $300 for a course of therapy, so it's available, but again, its benefits are extremely modest, and it's going to be, in my mind, an unusual situation to use them. That being said, there's some clinicians that put every single patient that they have that they believe have flu on these medications. Pertussis, as noted, whooping cough is a pretty substantial disease in children under, say, 18 months old or so. It's droplet passed. The child, if they're very small, can develop the whoop. That's actually the inhalation in between coughs, not the coughing themselves that sound whoop-like. They can cough for 2 or 3 weeks, very severely, and then have a persistent cough after that. In China, they refer to pertussis as the 100-day cough. It does seem to shorten some if we do give them antibiotics. On the other hand, oftentimes they'll have a long-term cough. It's sometimes very difficult to figure out what's going on in someone that comes in with a 3 or 4 week cough, because pertussis is on the differential, post-bronchitis cough is on the differential, as well as asthma and GERD and all the other things that you would normally think of with a persistent cough. Testing for pertussis, you need to do a nasopharyngeal swab. There is PCR and culture available as well, depending on the severity of the illness and how sure that you want to be that this person has pertussis. So just keep an eye on your options, know what's available to you. Again, people that are hospitalized obviously get more specific and sensitive testing. When someone has pertussis, antimicrobial treatment will make them better, but it also will make them less infectious. So you do want to get them on treatment as soon as possible. They need to be excluded from school, work, or whatever activities that they would be doing for the first 5 days of treatment. So for Zithromax, that's basically the whole treatment. If someone is confirmed case, we will give chemoprophylaxis to their household and other close contacts. And again, children should receive the DTaP, and adults and adolescents should receive the Tdap, noting that the D and the P are small letters, meaning a smaller dose in the Tdap versus the DTaP. So Tdap should be given to anyone over 65 who wants it, especially those that have children. The TD is substantially cheaper. Tdap is not covered by straight Medicare, although many Medicare D programs will cover it. You do want to make sure that if anyone has any at-risk injuries that you update their Tdap. And so if someone has any cuts, scrapes, bumps, bruises that would be risk for tetanus, then that gives you the opportunity to update their Tdap. So vector-borne diseases, and mostly we're going to talk about tick-borne diseases, the arboviral diseases, West Nile and Tripoli, would be substantial presentations. They would be someone that looked really sick, usually would end up hospitalized. It would be unusual to test for these in outpatients, although if you have somebody that really fits the pattern as far as having an encephalitis, severe headache, severe neck ache type issue, you could do the testing. The only times I've ever done it, I've actually called and talked to an epi at the main CDC about which test to do and how to do it. And again, in general, they're not very concerned unless the person is hospitalized. Tick-borne diseases, I'm going to talk about Lyme, Babesiosis, and Anaplasmosis. Ehrlichiosis is really not found in this area. We used to call anaplasmosis HGE for human granulocytic ehrlichiosis, but the terminology has actually changed to anaplasmosis, so I will use that terminology. So Lyme, I think everybody in the world has some familiarity with Lyme disease at this point. We all know it's the deer tick. We know that the Ixodes scapularis tick is often very difficult to identify with absolute certainty. It's a very small black-legged tick. However, there are other small black-legged ticks in the Ixodes family. The squirrel tick, the fox tick, those other ticks are essentially identical in gross appearance. You have to look at them under the microscope to really be sure that it's an Ixodes scapularis. This issue can actually be helpful if you have a child who comes in. If the parents have saved the tick, you can actually send the tick to Maine Medical Center for analysis, and they'll identify whether or not the tick is the Ixodes scapularis. They will not actually test the tick to see if the tick does carry the bacteria, however, just because I guess technologically that's not that easy, and the feeling is that that's not that helpful, that if you've got somebody who's got an Ixodes scapularis bite, then you're probably going to treat them either way. So the classic symptoms of Lyme, the flu-like illness that one might get, fatigue, fever, headache, arthralgias, and myalgias. This is going to be a couple of 3 weeks after the tick bite usually. The erythema migrans rash is the classic. It's pathognomonic. You can make the diagnosis just on the basis of that one finding. It is usually anywhere from 3 to 33 days after the tick bite. Has the classic appearance, has to be at least 5 centimeters across, and I have a picture on the next slide of what it looks like. Remembering that with late manifestations, joint swelling, etc., you actually do have to give a slightly longer treatment. So the erythema migrans, again, has to be over 5 centimeters. Note that it's not necessarily at the site of the bite. This says 3 to 32, but I've always learned 3 to 33, and maybe it's because I like to perseverate on 3s. It often will expand up to 30 centimeters, get bigger and bigger. The reference that I used when I made up these slides said 70 to 80% of cases will get the EM-type rash. I've also seen estimates as low as 50%. So the take-home for this is definitely not everyone gets the EM-type rash. So you do need to be aware of Lyme, even in people that have not had an EM-type rash. You can actually culture for Borrelia burgdorferi. However, the usual way of testing is to do an ELISA. If the ELISA is positive, then it reflexes to a Western blot, and the Western blot does the IgM and the IgG. The IgG may stay positive for life, although in most patients, if you treat them early enough, it will convert back to negative. There are concerns about the sensitivity of this testing, but the Infectious Disease Society of America says that as long as you're not doing it too early, it should be accurate. So beware of the patient that gets a tick bite, goes to the emergency room 3 days later, has a Lyme test and is told, don't worry about it, you don't have Lyme, just because it may take a month to 6 weeks for this test to turn positive. So that patient should probably be retested, and you need to keep that in mind. Does Lyme disease go chronic? Well, the CDC actually has included something on its website now called PTLDS, which is post-treatment Lyme disease syndrome. So the CDC and the Infectious Disease Society of America do recognize that the effects of Lyme disease might be lifetime. On the other hand, the issue of whether or not Lyme is truly a chronic infection is very controversial. So the Lyme literate practitioners will often diagnose something called seronegative Lyme. They basically will say, yep, this person acts like Lyme, looks like Lyme. I can't find any evidence that they have the Lyme bacteria. I can't find any evidence that they have Lyme antibodies, but I'm going to go ahead and treat them as if they did. Some of these patients do seem to get better. The challenge, of course, is they might have gotten better on their own, and or they might have some kind of other infection that is possibly treated by these antibiotics. Even the Lyme literate practitioners have started to recognize this. There's a great interest and a great emphasis on Bartonella infection, which is kind of beyond what I want to talk about here. But just be aware that often these patients will come in and will tell you that they've also been diagnosed with Bartonella, again, usually by symptomatology. So it is very difficult if you have someone come in and they're very convinced that they have Lyme. I do heartily encourage them to allow me to rule out a number of other things, including arthritises and chronic illnesses that would mimic Lyme. So basically do a reasonable lab panel. However, sometimes all of your testing is negative and they still feel lousy and they still feel like they have a brain fog and they still feel really poorly. At that point, you have to decide what you can offer them. Some patients will respond to antidepressant treatment at that point. Other patients do seek out a Lyme literate or alternative practitioner. Again, I tell people that as long as we've ruled out the more serious stuff, that there's not a whole lot of hard science that goes with this, but the potential benefits might outweigh the potential risks, and that it's really up to them. So the Lyme literate practitioners will also do something called the IGeneX test. The IGeneX test is only approved in California, does not meet the standards to be approved in the other 49 states. The people that I've seen, a high percentage of them will test positive on the IGeneX test. This raises the question of whether the regular test that we do for Lyme is not sensitive enough, or if the IGeneX test might in fact be overly sensitive and be providing a lot of false positives. So whether the regular test provides too many false negatives or whether the IGeneX test provides too many false positives, I'll leave up to your assessment to try to parse that out with each individual patient. There's other testing that Lyme literate doctors will do: CD57, homocysteine, MTHFR genes. Again, the potential benefits of these are not really demonstrated by the mainstream literature. On the other hand, sometimes they do get people better that we can't get better. The movie Under Our Skin is worth a watch. It's actually kind of an interesting movie. They did seem to try to base it on and The Band Played On. And The Band Played On was a book and a movie by a gentleman, I believe his name was Randy Schultz, who was involved in the AIDS epidemic and how that was ignored and swept under the rug, and the federal government denied that it really existed for several years. They seem to try to make the case that Lyme is the same kind of situation. I'm not sure that they actually do, convince people of that, but they do review a number of different issues and some of the evidence that there may actually be a minimization of the plight of the folks with this issue. Anaplasmosis is a condition that I guarantee you will be seeing progressively more over the next several years. This is a patient that comes in with a flu-like illness, often tests negative for the flu, continues to be sick for a week or so afterwards. They come in 3, 4, 5 days later, you draw blood work, and you find that their white blood count is low, as you might expect with a viral illness. But they often also have low platelets. They may or may not have memory of a tick bite, similar to the folks with Lyme, just because the Ixodes scapularis is such a small tick. It does seem to be passed by the same tick as the Lyme disease issue. It does also respond to doxycycline. So I think there's a number of patients from several years ago who would come in saying they had Lyme disease. You would put them on the doxycycline. They would feel dramatically better. In fact, a percentage of those patients probably had anaplasmosis. Does not seem to go chronic, although, again, I don't think we understand it very well by the fact that we're still in the process of changing the name. Babesia is a fascinating condition to me, and I think that probably a lot more people have Babesia than we realize. Babesia also presents with a flu-like illness, fever, chills, sweats, headaches, body aches, all of the usual. Again, if the patient is sick enough and they go to the emergency room and infectious disease gets involved, they're going to do a smear, they're going to do a PCR, and they're going to be way more likely to pick up babesiosis. The challenge with babesiosis is that it will not respond to doxycycline. It needs a combination of atovaquone and azithromycin, or clindamycin and quinine. So the challenge is that you need to have this on your radar. Their labs will often look a lot like the anaplasmosis patients, although they'll also usually have a transaminasemia, high liver function tests, and that raises the specter of Babesia on your differential. The other thing, of course, to remember when you have high liver function tests is that mono can often present with high liver function tests. We usually don't know because we usually don't do a chemistry profile in those people. Their liver function tests can actually get high enough to be jaundiced. Babesia patients also can, although in my experience it seems to be a little bit less often although I've only seen a handful of Babesia patients. So again, the Babesia diagnosis is often very difficult. You have to have a smear, maybe multiple smears. You have to have somebody that's really experienced in reading those smears, so the pathologist really has to look at this, and the PCR will often confirm or dispute that finding. Like malaria, it can actually wax and wane, and especially if you've got someone that was not adequately treated. It is a complicated, difficult infection, and there's probably a percentage of people that believe they have chronic Lyme that actually have chronic Babesia that has not been adequately treated. So again, the challenge with it is it's often a very difficult diagnosis to make. Meningococcal disease, Neisseria meningitidis, not very common. Unfortunately, if it does happen, though, The possibility of death is about 1 in 10. Rates 5 to 15%. Also, though, there are a number of patients that will end up with amputations from vasoconstriction that is so severe that basically the arms become ischemic. You can find pictures online. This baby, actually, in this picture, might very well have some ischemia in those feet related to this. Oftentimes, those patients will end up with amputations. Really enjoyable, interesting movie, I think, is Murderball. Murderball is the people that are quadriplegic rugby players, and it's worth watching. So meningococcus, again, is transmitted through droplets. If you are exposed, there usually will be some prophylaxis, although usually the prophylaxis is just a single tablet of Cipro, or capsule, I should say. Not usually a hard diagnosis. These kids usually look really sick, and usually they are kids. They'll have this rash, they'll start looking floppy, their neck will be stiff. Obviously the earlier you diagnose it, the better. But if you have someone that has suspicion, then obviously that person needs to go to the emergency room immediately. In the ER, they'll do a spinal tap, they'll do blood cultures. Again, we do usually want to vaccinate people. The benefit of vaccination is, to be honest with you, relatively modest, but in a very severe illness like this, the general feeling is the benefits outweigh the risks. The hepatitis A is the least severe. You usually will not die from hepatitis A, and it usually will not go chronic, essentially never. People that get the hepatitis A vaccine, obviously children get it, and it's 2 doses 6 months apart. If someone is traveling, if someone is a man that has sex with men, chronic liver disease, all of those people are usually going to get a hepatitis A. People with chronic hepatitis B or chronic hepatitis C, if they get hepatitis A, it's usually way more fulminant and way more dangerous than in people that do not have those infections. Sewer workers will often seek out immunization. It's totally reasonable to give it to them, although the benefits are very modest, and CDC says that there's really not been any documented cases of sewer workers getting hepatitis A from working in the sewer, so they don't recommend that sewer workers get the vaccine, but some municipalities know that it is passed in stool, so they will offer it to their employees. I don't think there's any real harm in doing that. Food service also in general is not immunized. Again, if there was an outbreak, I guess we could think about doing that, but the incidence of hepatitis A is so low that it's not usually done. Clinical case, obviously, there's usually going to be a specific onset. They're going to have some nausea, some malaise, some fever, anorexia, some belly pain, and they're going to have notable jaundice, and when you check their transaminases, they're going to be markedly elevated. Symptoms usually last a couple of months. I always tell people that you're not going to die from hepatitis A, but you might wish you could, just because you're going to feel pretty sick. Obviously, this is not something you want to get in a foreign country, so if you are in a place where it has a high incidence, you do want to be immunized ahead of time. Incubation period is about a month, so if one's only going for a few weeks, that's less of an issue. You would be sick when you got back, but again, you still don't want to get it. 10 to 15% of the people that get it will have relapsing disease up to 6 months, but again, it does not go chronic per se, and is not a lifetime disease. You probably already know a lot about hepatitis B. Hepatitis B is through intravenous or other bloodborne activities, as well as sexually transmitted. Again, those patients will usually have an acute onset similar to the hepatitis A patients, some nausea, vomiting, abdominal pain, joint pain, jaundice. Again, when one presents with these things, you're going to have to do a differential, and usually we'll go ahead and we'll test for the acute labs that one would have in hepatitis A, hepatitis B, and hepatitis C. If someone is chronic, they may not have any symptoms until the hepatitis B causes enough damage to their liver that they become cirrhotic or possibly develop a liver cancer. So if you have someone who has elevated liver functions, you could think about doing hepatitis B testing. The acute serology is the surface antigen and the core antibody test, specifically the IgM core antibody. Chronic serology would be the surface antigen, and that infers continued infection risk. So if someone has surface antigen positive, they can pass the virus to someone else, as well as the other testing that can be done for chronic infection. So obviously when somebody has hepatitis B, interestingly, a percentage of patients will actually turn immune. Substantial number of people will turn immune rather than go chronic. So if you have hepatitis B, then you definitely want to have follow-up testing. Make sure you turn surface antigen negative. Make sure you do not have evidence of chronic infection. If you don't, then you don't need to do anything else. You will be immune. You will develop surface antibody positivity, which will infer lifelong immunity, just as you would if from the hepatitis B vaccine. If you continue to be surface antigen positive and don't develop surface antibody positivity, you may have developed chronic hepatitis B. In that case, you need to be referred for treatment, usually to gastroenterology. They are the ones that usually treat hepatitis B, although infectious disease, I think, probably could do that. The usual medication that I've seen is Baraclude. There's probably others. But basically, it's an antiviral that's specific to hepatitis B that usually will control the hepatitis B. Some patients, it seems to clear it. Other patients, it just keeps it at bay for long periods of time. Obviously, as we said, you give that person the hepatitis A vaccine. You screen contacts, especially sexual contacts, and you educate them and counsel them. Babies that are born to surface antigen positive mothers will get the vaccine and follow-up testing. And there is routine vaccination for all children for hepatitis B vaccine. Now, hepatitis C, again, has similar symptoms: the nausea, the vomiting, the jaundice, the elevated transaminases. You'll test specifically for the hepatitis C antibody to test for acute infection. If they have hepatitis C infection, they can actually clear it and become immune, just like the hepatitis B patients. Percentage-wise, that's a much lower percentage, though. It seems to be maybe 5 or 10% that do that. Way more likely to go chronic than the hepatitis B patients. If they do go chronic, then there are treatments available now for most of the genotypes, definitely for genotypes 1 and 4, and occasionally genotype 3, which takes care of the majority of cases of hepatitis C, but not for everybody. Not all people will respond to Harvoni. But either way, if you've got somebody that's hepatitis C positive, they've got to go see GI, and then they'll evaluate whether or not they're a candidate for medication treatment. This concludes part 1. More to come in part 2.